Again, you can review this in the Minnesota film, but we'll quickly review a few points that may help. In order to easily locate the ovaries, put the uterus back where you found it. That is, don't try to palpate ovaries while the uterus is in the retracted position. You'll likely get disoriented. The ovaries lie in the broad ligament on either side of the body or bifurcation of the uterus. Simply slide your hand down the cervix to the body and move to one side or the other. In nearly all cases, you'll feel the distinct lump that is the ovary. Gently slide your hand under it, opening a space between your middle and ring fingers in which to cradle the ovary. Now you're free to palpate the surface with the thumb and index finger. In order to more easily differentiate ovarian structures, consider the following. Follicles are essentially a vesicle. That is, if you envision a fluid-filled blister, you have a good idea of what you're palpating. In contrast, the word corpus, as in corpus luteum, means body. That is, instead of fluid, the corpus luteum contains glandular tissue, which often has a liver-like consistency. Most corpora lutea have a papilla, or crown-like projection, above the surface of the ovary. This projection and its liver-like firmness generally make this CL easy to diagnose. Note that the entire ovary is distorted from its normal almond shape. Some CLs, though, have no papilla. In these cases, it is useful to remember that the papilla, when it is present, is only the tip of the iceberg. The majority of its substance is within the ovary. Therefore, deep palpation of the ovary will most often reveal a distinct line of demarcation between the bottom of the CL and the stroma of the remaining ovary. This waistline, or equator, is usually palpable with the tip of the thumb. Note again that even without a papilla, the shape of the ovary is distorted from its normal outline. Ovarian cysts are palpable as overly large follicles. For sake of simplicity, we'll define a cyst as any fluid-filled blister of more than 20 to 25 millimeters diameter. The ovarian bursa, although not routinely palpated, can be examined in cases of repeat breeder cows who cycle normally but who do not conceive. To examine them, pick up the ovary as before and hold it in the thumb and index finger, while the other fingers slide down the lateral side of the mesovarium and broad ligament. Usually, the fingers will hook into the bursa, which can then be inverted, and its oviduct palpated with the fingers and thumb. Although they are present much earlier, most palpators will first recognize them at this stage. Some texts list an order of increasing fetal age based on the size of the palpated placentome. While this may be the only finding to hang your hat on, remember that this method is fraught with inaccuracies because there is considerable variation of placentome size within the same uterus. Therefore, two palpators may find two different placentomes and thus assign different ages to the same pregnancy. The finding of fremitus in either or both middle uterine arteries is, with rare exceptions, consistent with advanced pregnancy, that is, beyond 120 days. Fremitus will occur in the artery supplying the pregnant horn only until about the 7th month, when both arteries may have fremitus, although the pregnant side's artery will be larger. Finding of fremitus in both middle uterine arteries when they are symmetrical is indicative of twin pregnancy. Palpation of the ovaries of pregnant cows is not often necessary, except occasionally to locate the side on which the ovulation and the pregnancy exist. This would only be necessary if the vesicle or the fetus itself was not palpated, and a secondary sign of pregnancy, such as a membrane slip or placentome palpation, was used to determine pregnancy. The CL is located ipsilateral to the pregnancy in nearly all cases in cattle. Exceptions are extremely unusual. Often, the CL of pregnancy will have no palpable papilla and will be quite soft due to remodeling and vascularization. In these cases, beginning palpators are often tempted to diagnose a cyst and may even attempt to rupture it. The disastrous consequences of such a mistake would be easily avoided if the uterus is palpated first before the ovaries. The finding of a pregnancy would dictate that ovaries be treated gently. In general, the larger, softer of the two ovaries is the one containing the CL of pregnancy. Endometritis. This will palpate as a thickened uterus with doughy tone. A discharge may or may not be seen on vaginal examination. Pyometra. This can easily be confused with pregnancy. The uterus is heavy and fluid-filled, but does not have a membrane slip, nor placentomes, nor a palpable fetus. Almost invariably, a pyometra will be associated with a corpus luteum. That is, the uterus will be under continual luteal influence. There may or may not be a discharge from the cervix or vagina, so that speculum exam can easily miss a true pyometra. It is necessary, therefore, to be able to diagnose this condition rectally. The palpation of a distended, fluid-filled, flaccid uterus without a membrane slip and in the presence of a CL should tentatively indicate a pyometra. Uterine adhesions. Depending on severity, these may or may not be palpable. Following inflammatory disease of the uterus, fibrin tags may develop on the serosal surface of the uterus. These may subsequently organize to permanent fibrous adhesions. Some are severe enough to adhere the uterus to surrounding structures, most often the greater omentum. Minor adhesions, where a portion of the uterine horn is adhered to an opposed portion of the same horn, are more subtle and may be missed. Uterine abscesses, protruding from the surface of the uterus. Firm. A common location is just inside the internal cervical os, where an overzealous pipetter sometimes forces entry into and through the uterine wall. There is an important distinction between fetal mummification and fetal maceration. The mummy results from a relatively sterile death of the fetus. That is, there is little or no bacterial degradation of fetal soft tissues. The fluids are gradually resorbed, leaving a uterus which is doughy with a pitting, tar-like quality to its contents. The uterus is not distended, but is closely applied around the firm, tarry mass which is the fetus. Very little endometrial pathology is associated with this condition, surprisingly enough. And if the mummy can be medically or surgically removed, the long-term prognosis for reproductive recovery is fair. There is little or no offensive odor associated with this condition. Fetal maceration, however, occurs when the fetus dies and its soft tissues are bacterially digested, leaving a somewhat distended uterus containing a foul-smelling fluid and sometimes palpable crepitant bones. If the condition is long-standing, the fluids may be partially absorbed, leaving a smaller uterus which is distended only over the area of crepitance. The prognosis of this condition is very poor, as considerable and often irreversible damage is done to the endometrium. Both of these conditions, mummies and macerated feti, are associated with the presence of a persistent CL. The most commonly encountered pathology of the dairy cow's ovary is the ovarian cyst. These are, as stated, fluid-filled structures greater than 20 to 25 millimeters in diameter and associated with improper release of pituitary luteinizing hormone. The finding of a fluid-filled structure greater than 20 to 25 millimeters in the ovary of a non-pregnant cow should be tentatively diagnosed as a cyst. These cysts may be of at least 3 types. These palpate as overly large follicles, often with more than one in an ovary. They are very thin-walled, tense, and fluid-filled. They will distort the size and shape of the ovary considerably. Some can be easily ruptured by applying mild pressure, roughly equivalent to what might be necessary to crush a very ripe grape. These are pathological cysts. These can be just as large as follicular cysts, although the wall may be somewhat thicker. The lining contains considerable luteal tissue, giving the palpator the impression of a tougher cyst wall than a follicular cyst. Sometimes there will be a rim of palpable luteal tissue at either the base or the top of the cyst. These are pathological cysts. They are difficult to differentiate from follicular cysts. These are also large, fluid-filled structures on the ovary, but generally they will have a subtle but palpable papilla, indicating that they have ovulated. The wall is generally considerably thicker, and there may be a waistline in the ovary at the base of the CL. These are generally considered not to be pathological structures. These may be suspected when the ovary cannot be freely picked up from the normal position on either side of the uterine body. The ovary may be embedded in portions of the bursa or in the broad ligament. The significance of this condition is that ovum transport may be affected. It should be noted that some cows have a short mesovarium, and therefore one should not diagnose ovarian adhesions simply because the ovaries don't travel easily. Abscesses, like cysts, will greatly distort the size and shape of the ovary. Unlike cysts, They will usually be firmer, with perhaps a fluctuant cap. They are often associated with ovarian or peri-ovarian adhesions. Let me make a comment about so-called smooth ovaries. There's a time in every cow's cycle, that is between day approximately 18 and day 5, or day -2 from estrus to day +5 after estrus, when the normally cycling cow will have very few palpable structures. These can be mistakenly labeled as inactive ovaries if repeat palpations on the same cow are not performed. Therefore, the diagnosis of smooth ovaries or inactive ovaries would require repeated examinations to confirm. The passage of an insemination pipette per vagina into the uterus should be done cleanly and fairly quickly to avoid problems associated with excessive straining. The vulva should be cleaned, and then a hand passed into the rectum to grasp the posterior portion of the cervix only. The cervix is then pushed away from the palpator in order to straighten out the vaginal canal so that the pipette will not snag on any vaginal epithelial folds. The pipette is introduced through the dorsal commissure of the vulva and passed quickly to the anterior vagina, where the trailing fingers of the hand in the rectum can locate it. With these fingers serving as a funnel, the pipette is guided into the external os. The rectal hand then regrips the cervix in the normal palpation manner and gently manipulates the cervix up and down, left and right, over the pipette. Note that the pipette is not pushed through the cervix, but rather that the cervix is guided over the pipette. For most intrauterine therapy, the pipette would be passed only to the body of the uterus, that is, just beyond the internal cervical os. Note that the palpable bifurcation of the uterus is well beyond the actual bifurcation. It is therefore easy to mistakenly deposit either semen or medication in one horn only. To avoid this, palpate the tip of the pipette just beyond the internal cervical ring before depositing medication or semen.